Hello, my name is Dr. Samaan Rafeq. I'm an interventional pulmonologist at NYU Langone Medical Center in New York City. I would present today on percutaneous tracheostomy in COVID-19 respiratory failure, discussing specifically when and how to perform this procedure. I do not have any disclosures relevant to this presentation. We know in general that percutaneous tracheostomy is a common procedure performed in critical care units across the world. It is estimated that close to 10% of ICU patients would require tracheostomy at some point during their hospital course. That percentage would vary from one study to another or one hospital to another, but in general, it tends to be close to that number that we had mentioned. Percutaneous tracheostomy plays an important role in facilitating weaning and getting patients closer to discharge from intensive care unit into other hospital wards or outside of the hospital. In general, most tracheostomies are performed around the 2-week mark of patients' intubation and mechanical ventilation. There have been many studies in the past that looked at early versus late tracheostomy, and the conclusive evidence from all of these studies seem to confirm that a 10 to 14-day mark would be appropriate for performing of this procedure. However, with that being said, there are certain circumstances when tracheostomies are performed much earlier in the course. Those include cases with traumatic brain injury, other general trauma, or in neurologic conditions that are seen, namely myasthenia gravis or other conditions that are expected to last for a long period of time, and therefore patients are trached earlier in their course than waiting for the 10 to 14-day mark. When COVID-19 started to hit and many patients were developing respiratory failure as a result of that, the question of percutaneous tracheostomy came into the picture. We know from prior epidemics and pandemics that tracheostomies play an important role in care of these patients. At the beginning of this current pandemic, there were many society recommendations that have come out against performing tracheostomies or for delaying that procedure in patients who were diagnosed with COVID-19 related respiratory failure. Those recommendations were based either on historical data from prior epidemics, pandemics, based on expert opinion, and those were in place in order to protect healthcare workers from the risk of transmission of COVID-19, and also to have a better idea about the clinical course of those patients. Therefore, when the pandemic started to hit Asia and Europe, most of societies, as I had mentioned earlier, had come out with specific recommendations to either delay or avoid tracheostomy altogether in this patient population. Indications for performing percutaneous tracheostomy, however, in this patient population should not differ much from what we know in the general population. It is for prolonged mechanical ventilation. It is for secretion management, as a lot of patients have difficulty with secretion clearance despite aggressive airway toilet. Those patients tend to have thick secretions, they tend to be weak, and they tend to have poor or depressed cough mechanism. Also, this is indicated in patients who fail extubation and who have a very high risk of reintubation, either failure or complications due to the urgent or emergent natures of reintubation should that arise. There are a lot of known complications that apply to general critical care patients, and it's not any different in COVID-19 patients with respiratory failure. That includes upper airway and laryngeal complications, such as development of laryngeal edema or other mechanical complications from laryngeal endotracheal intubation. Specifically in this patient population, when the pandemic started to fill ICU beds with patients, there was a high number of patients in those ICUs that were requiring mechanical ventilation. So that led a lot of institutions to think about tracheostomy, despite the early warnings that we had talked about with avoiding or delaying tracheostomy, in order to mobilize patients out of intensive care units and to make room for other critically ill patients that need that level of care. With that, we have to take into account all the available resources and make sure that we maximize all available resources, whether it's personnel, equipment, or expertise at any particular institution. There has to be a multidisciplinary approach to patients who might require tracheostomy, and that includes the medical teams taking care of patients in the intensive care unit, the procedural team that will be performing the procedure, and even ethics and other patient family related services that have to take into account what the prognosis is and what the implications for a trach might be for long-term care of those patients and where and how it facilitates that care after their intensive care unit stay. With regards to patient selection, patients would have to be stable from a cardiopulmonary and hemodynamic standpoint in order to be considered for tracheostomy. So patients who have significant hemodynamic instability or are in any acute cardiopulmonary phase where they're still requiring a high level of fractionated oxygen support or positive pressure would not be a good candidate for this procedure. We try to minimize the number of organ failure that these patients have, with few exceptions. So with regards to renal failure in particular in patients who are on renal replacement therapy, those patients could be considered for percutaneous tracheostomy. However, once we start to have multi-organ failure, it is then advisable to wait on performing this procedure. We would like to see patients who do not have any anticipated needs for proning, and I will discuss that in a future slide. And then they have to be adequately managed from an anticoagulation standpoint with no significant coagulopathy that would preclude them from having this procedure done. Timing has been debatable, and again, going back to the early recommendations from societies to avoid or delay this procedure, which we know practically would not be feasible in many institutions that are caring for these patients. There was a large international paper that came out with expert opinions with suggestions and recommendations that have recommended waiting for at least 10 days before considering percutaneous tracheostomy for these patients. And again, they recommend that any approach should not be a departure from all the standard best practices as far as timing and management of tracheostomy. The technical approach could be either a percutaneous tracheostomy, which is the subject of this talk, an open surgical, or a hybrid in between. Choosing one approach or the other has to do with the available resources and expertise at any given facility, and also to minimize patient movement, to try to minimize the risks for patients and risk of exposure for staff at various areas of the hospital. When we perform percutaneous tracheostomies, it is done most of the time at bedside. And even for surgical tracheostomies or hybrid approach, that could be done at bedside in the intensive care unit. But it is known with prior experience with percutaneous tracheostomy and other respiratory failure conditions that could be safely performed in an intensive care unit at the bedside. The percutaneous tracheostomy technique approach requires a lot of preparation to ensure safety of healthcare providers and to minimize the risk for patients while they're undergoing this procedure. It is advised that this procedure be performed either in a negative pressure room or that HEPA portable filtration system be placed in the room prior to performance of the procedure. There has to be proper protection for staff by using enhanced PPEs, including face masks, as well as surgical gowns. We believe that performing a bedside Doppler or ultrasound to evaluate the neck is of value. However, that has not been standard at all institutions, but if that is available, it is always advisable to use that in advance, both to mark the anatomical site and to minimize any risk of bleeding as a result of this procedure. Bronchoscopy guidance is always advised and indicated in this case. And we advise that we minimize the number of people in the room and to limit that to the person who's performing the procedure itself, the person who's performing the bronchoscopy, and a third person to help manage medications as well as the ventilator during the time. It is recommended that during any of the steps, and I will not go into too much details about the technical part because we recommend that people stick with their the baseline performance of these procedures and what they're comfortable in performing and what they've been doing for their practice. However, during times of interruption of closed circuit with the ventilator, we recommend that apnea be performed at that time. After the tracheostomy is placed, it is recommended that a bronchoscopy be performed through tracheostomy, both to confirm the actual position of the tube, as well as to clean any secretions in the airways. The trach is then secured using a trach collar, not using any sutures. It is recommended that the circuit then be connected to a heat and moisture exchange known as the HME filter to minimize the amount of air sterilization and to maintain adequate humidification of secretions. There has to be a post-tracheostomy care protocol in place, and that would differ from one institution to another, but that has to be agreed upon prior to performance of this procedure. There are some risks and disadvantages to performing tracheostomies in this patient population. We had mentioned earlier that proning should be limited, or proning has to be taken into account when performing this procedure, because proning would be limited after a trach is in place. Although it does not fully exclude the performance of the proning, however, that has to be taken into account. Pressure injury is a complication that could arise, as well as aerosolization. There is no clear evidence of difference in effectivity between percutaneous and surgical tracheostomies. As far as outcomes, there are still a lot of question marks in this patient population. Whether this helps with their weaning, as we know in general critically ill patients with respiratory failure, whether it helps to reduce their ICU length of stay, and how that might contribute to their mortality. So many more to come as we gather more information from different centers around the world as far as the outcomes for this procedure. Thank you very much for your attention.